Hi, I'm Sarah Hurvitz. I'm a medical oncologist and professor of medicine at the David Geffen School of Medicine at UCLA. So we have a number of endocrine therapy options for our patients with hormone receptor positive metastatic breast cancer. First, of course, tamoxifen, and then the aromatase inhibitors, and then fulvestrant. Fulvestrant is probably the most effective endocrine agent. Some data indicate it's better than aromatase inhibitors when given at the proper dosing of 500 milligrams monthly. The problem is it's poorly soluble, and so it must be administered by intramuscular injection, which a lot of patients are not really keen on having. 2 injections actually each month. And so a number of investigators and companies have come along developing oral forms of the estrogen receptor degraders. And in fact, at my last count, I think there were about 10 oral SERDs in development, which would be great for our patients to have a really effective endocrine-based option that's not intramuscularly delivered. It would also be great if it was a more effective option than our current therapies, and if this option was better tolerated. Our aromatase inhibitors are associated with a lot of systemic adverse events, including musculoskeletal side effects, et cetera. So we're all keen on having a new version of endocrine therapy to use as a single agent or in combination with other targeted therapies. The Emerald clinical trial was the first randomized study putting the oral SERDs to test against an aromatase inhibitor in the metastatic setting, and actually met its primary endpoint of improving progression-free survival compared to standard of care endocrine therapy. Although the data didn't show a huge difference in outcomes associated between the use of the oral SERD, elacestrant, versus standard of care endocrine therapy. As I said, it did improve outcomes for patients in terms of meeting its primary endpoint, and the tolerability looked reasonable. And I think this sets the stage for elacestrant to be looked at in combination trials, which are moving forward. There are a number, as I said, a number of other oral SERDs or other estrogen receptor downregulators in development, with lots of phase 1 and early phase 2 data emerging in the metastatic setting and neoadjuvant setting. We have drugs like giredestrant that are being evaluated. ARV-471 is another one. Amcinestrant recently had a press release indicating that it would no longer be further developed in the AMEERA-5 study due to a futility analysis. And so that's a bit disappointing to the field as a whole, but I don't think that that means we won't see oral SERDs developed further. I think this is a very active field of discovery, and I'm very excited to see the results of ongoing trials looking at these agents as a single agent, looking at these agents in the early stage disease setting, evaluating the activity of these drugs against tumors that have acquired ESR1 mutations where aromatase inhibitors are not helpful, and looking at these agents in combination.